This is Dr. Craig, and welcome to Top 10 Radiology. Okay, let's discuss breast cancer. Breast cancer is staged using the TNM system, which is found in the AJCC Cancer Staging Manual. Instead of looking at boring tables while I read, I try to include pertinent information in my reports, in theory, that help stage the cancer without actually having the information available. And so, for instance, for this cancer, I use these key facts. So for T staging, I would think about size, which can differentiate between T1 and T3 disease, with 5 centimeters being the cutoff, or looking at direct extension into the chest wall or skin being T4 disease. When looking at lymph nodes, I try to evaluate the ipsilateral axillary lymph nodes to see if there's any abnormal appearing lymph nodes, and then go to the thoracic inlet for any supra or infraclavicular lymphadenopathy, as well as the internal mammary lymph nodes, which follow the internal mammary vessels, as we'll show later. Lastly, I try to think about where metastatic disease is most likely to be found. In breast cancer, it's going to be the bones as number one, with the thoracic and lumbar spine being the most common, as well as followed by the ribs or pelvis and ribs. It's important to think about this 885 Hounsfield units cutoff, because anything less than 885 Hounsfield units is mildly or would be suspicious for metastatic disease, versus everything above it is going to be likely a bone island. But this cutoff does not work for treated metastases. You have to look to make sure that this is a true cancer staging study and not a reevaluation of sclerotic metastatic lesions. Next thing to think about is the liver, where there's multiple metastatic deposits are more common than just a few. And then in the lungs, where pleural effusion is more common than multiple nodes versus a single node. Next, let's talk about complications and pearls. Because breast cancer affects older women who likely have some degree of osteoporosis or osteopenia, I try to look for pathologic fractures of the spine. And I include retropulsion of the components, because that can actually affect the spinal cord if I do see it. Next thing I think about also is pathologic fractures, pathologic rib fractures specifically, because that's what can cause a lot of pain and can explain a patient's chest wall pain. The pearls of breast cancer are as follows. If you have metastatic disease in the axilla, the skipping of level 1 lymph nodes, which are lateral to the pectoralis minor muscle, it's really rare for it to skip that level. That's typically the seminal node, where it goes first, rather than to level 2 or 3, which is underneath the pectoralis minor muscle or medial to it. And when evaluating lymph nodes, you want to look at the appearance. It's more reliable than the size when you want to call abnormal axillary nodes. So if you see a nice fatty hilum or reniform shape and it's enlarged, it doesn't mean it's abnormal. And then lastly, a nice little Board's fact would be it can have dural involvement in the brain. So you might want to look for that.
Okay, let's review our first breast cancer case. This person actually has a biopsy-proven breast cancer on the right, and she underwent axillary node dissection, as you can see here with the surgical clips. But they're concerned because years later, they came in and they noticed that there was a significant left-sided axillary lymphadenopathy that were palpated on examination. And so they were reviewing this case to see if there's anything abnormal on the left side. By eye, I don't see any weird nodularity here that was going to tell me, or any speculated mass that is going to necessarily show me that something is there. But this would be further worked up, of course, by diagnostic breast center. What I do know are these abnormal left-sided axillary lymph nodes. And as you can see here, as we discussed before, is size doesn't really matter as much as morphology. And in this case, this is a blatantly abnormal lymph node that has a central calcification, it appears, right there. And then similarly, there's a group of abnormal lymph nodes as we go more medial. And so again, as discussed before, this is the pectoralis minor muscle, and this is the pectoralis major muscle. And so anything lateral to the pectoralis minor muscle is going to be considered level 1. So there's a group of level 1 lymph nodes, and then 2 or 3 abnormal appearing level 2 lymph nodes. As you can see here, there's also these other lymph nodes, which, while do appear large, they maintain their normal fatty hilum and reniform shape, so those are less likely suspicious for malignancy. If you look here on the right, this is another good point, is this lymph node actually was PET positive for malignancy. And so size doesn't necessarily matter. And I don't know if I would have picked this off in a random study, but in this case, this was positive. So after looking at this, I'm going to say this person does have left-sided breast cancer and they do have left-sided axillary lymphadenopathy. I'm going to look all the other places, and so possibly on the right, and then internal mammary. And so these are their internal mammary vessels, and so I want to follow those down. That's where I would see the abnormal finding. As discussed before, bone is the most common, so I'm going to be looking for bone mets. And based on a very quick review on this examination, I didn't see any. Again, I want to rule out, bone island versus sclerotic met if I did see one, but I don't see one in this case. Everything looks fine. And then I want to look in the lungs, and everything looks good there. And then finally, we would be looking at the liver. In this case, we don't have any contrast on board, but we would want contrast if this was a diagnostic examination. I would put it on liver windows just to make sure that everything is okay here. And I don't see any, hypoattenuating mass in this case, on this limited case. Okay, let's review our second case of breast cancer. So as we go down here, you'll notice this large mass that's extending through the chest wall into the anterior mediastinum as well as the lung. So in this case, because of T and M staging, it goes to the chest wall, so it's already T4, but this is going to be greater than 8.1 centimeters. So we know that would be a T3 if it wasn't going through the chest wall. Now, if we follow down, I'm going to look for internal mammary lymph nodes. And as you follow this, I think this would be actually considered one as we go up higher, and then as we go lower, because we're following the internal mammary vasculature. And so again, if I'm looking for metastatic disease, first of all, one thing that catches my eye here is there's a pleural effusion, and due to close contact of this malignancy with the pericardial sac, I'd be a little bit worried that that's malignant, although there's no nodularity that I can tell. But just a quick run through the lungs demonstrates no nodules or pleural effusions. And then as I go through the liver, there's something that caught my eye, but I want to double check. Putting it on liver window, you'll see that this kind of stands out. And so in this setting of breast cancer, I would be highly concerning. This is highly concerning for metastatic disease. And then lastly, we're going to take a quick look at bones. Bones, to me, the quick run view that I look at is I try to look at everything straight, and it's kind of challenging to do that regarding ribs, but I've kind of figured out the method that works for me. Sternum is, first of all, on the sagittal view here, the spine, you can see the spine so well, and so that's where I always go when reviewing spine stuff. The sternum is also one of those, hidden bones that not a lot of people look at. A lot of residents miss that, but you can see here that this is actually just straight up invading it, and that could be confirmed later as you lose the cortex anteriorly. And so looking at ribs, you know how ribs are curved, but I want to look at it on a straight field. So the best way is to look at it on two fields, and that's sagittal and coronal. So on sagittal here, I'm just trying to get the most surface area I can of each rib as I review it. And this actually works pretty well for fractures as well. So based on that, I don't see anything. And then coronal, our best view here is looking posteriorly, because that's where you get the kind of the most surface area. So as a result, I don't really see anything there. So I don't necessarily think there are any bone mets outside of the direct invasion of the tumor to the sternum.